and a very warm welcome to today's online event here at the King's Fund. We're going to be looking back over the first year of the integrated care systems in England and also looking forward to think about the next steps in the development of integrated care. I'm Anna Charles, I'm a Senior Policy Advisor here at the King's Fund, and I'm joined for our discussion today by our very own Chris Ham and also by Don Berwick and Claire Fuller. I'd just like to ask each of you to introduce yourselves, starting with you, Chris.
Hi Anna, I'm Chris Ham, Chief Executive of the King's Fund.
I'm Claire Fuller, I'm a GP and I'm the lead for Surrey Heartlands ICS.
And I'm Don Berwick, I'm International Visiting Fellow at the King's Fund.
Well, thank you all for joining us, and thank you to our online audience for joining us too. I know we've got a huge number of you signed up today from across different organisations in the NHS, local authorities and patients and users as well. I'm just going to say a few words about how the session is going to work before we get into the conversation today. So we've got about an hour. I'll start off by asking a few questions to Chris, to Don and to Claire to set the context and also just to get the discussion started. But we're going to use most of the time we've got this morning to take questions from you, our online audience. So please do send those in early and send them in frequently. You should be able to see on your screens a box where you can type in your questions and comments and send them through to us. As you send them through, I'll be able to see them on a screen I've got in front of me here, and I'll then feed them through to Chris, to Claire and to Don. So I think we're ready to get started. Chris, I'd like to come to you first, if I may. Some people in our audience might not be familiar with the work of the integrated care systems. I know that you've spent a lot of time over the last year or so working in all the different systems, seeing the work they're doing. So for the uninitiated, can you just give us a brief overview of what these systems are and what they're for?
Integrated care systems are partnerships within the NHS of the hospitals, the commissioning organisations coming together around a defined population, and often in partnership with others like the local councils or the voluntary sector organisations. They have no legal basis. These are entirely voluntary collaborations set up by NHS England at a national level to plan improvements in health and care for the populations covered by these systems. There have been 10 over the last year, 4 more have recently been added, and they've evolved out of the old sustainability transformation plans and partnerships to take forward that work and to use the resources available to the NHS to bring about the maximum benefit for their populations. It's very early days, and we've seen in our work some encouraging examples of the improvements that are now beginning to take place. But there's a huge amount more to be done, and what we're hoping is that over the next year or two, we from the King's Fund can continue to work with these systems and the new ones that are being identified, because this is the future. It's the future based on collaboration, not competition, partnership working, recognising this work is important but not easy because the systems have no basis in law, and they do require, just to repeat myself, the commitment of the statutory organisations running the hospitals and providing the commissioning support to work in this way.
It's a very helpful overview. Thanks for that, Chris. So Claire, you've actually been working in one of these systems, leading the changes in Surrey. So can you tell me a bit about what's it looked like for you in Surrey? What have you actually been working on?
Yeah, so I lead a footprint called Surrey Heartlands, which obviously I will probably be the only person to say I come from Surrey Heartlands. It is not a real place. It is most of Surrey, but not all of Surrey. Cover a population of 850,000. And Surrey historically has been quite tricky because we're really close to London and we have patient flows that naturally go in, obviously into London, into Sussex, into Hampshire and into the Frimley system. And we've tried over the years a number of ways of dealing with that, including sort of trying to build a wall or trying to ignore and actually this time we've decided to embrace the flows as they go and work with them and work in partnership. I think there's 3 things that differ in our footprint, as was STP, from the other 43 around the country. So we have a devolution deal. So we've been very fortunate that we've had really strong committee leadership from our local authority, from Surrey County Council. Firstly, from David McNulty, who has subsequently become our independent chair. And then his successor, Joanna Killian, again, has been really supportive and really closely involved in everything we've done. We've done a lot of work, again, through being led by Surrey County Council on the way we have tackled citizen engagement. And then we've done a lot of work on clinical engagement and how we harness the clinical voice across Surrey.
And Claire, Chris described that shift from competition to collaboration and made the point that it's not easy in the context of the system architecture and the laws that we've got. So how have you gone about tackling that in Surrey Heartlands? How have you made progress in spite of all of that?
So we've spent a lot of time actually building the relationships at the most senior level. To start off with. So we worked with a chap called David Berg, who's a professor of organisational psychology from Yale. And he's come over and we've spent a long time actually talking about the things that have got in the way in the past. So we've had acute trusts that have been involved in transactions that haven't worked, involved in mergers that haven't worked, and all of that brings complexity into any conversation that you have. So we've spent a number of days and a number of hours actually all talking about the things that get in the way, to the extent that I'll look around the room and think, we'll never put this back together again. And somehow you always do, don't you, with these things? And from having built the trust, so it's Rob, we were talking about this earlier, so Rob Webster in Yorkshire says integration at the speed of trust, which I think is absolutely probably the truest thing I've heard in a long time. So until you have got the relationships in place, you cannot move forward because you're not having an authentic, honest conversation about what you want to do and why also why you cannot do things.
So relationships ahead of structure in your case. Yes. And Don, you're a regular visitor to the NHS and you have been for many years now. And I think you've been out as well to see some of these systems, to see firsthand the work they're doing. So what are your reflections on what you've seen? Is there much going on? Are you encouraged by what you see?
There's a lot going on. I'm very encouraged. I've been coming here since really 1996. I think it was my first engagement with the National Health Service, so it's 20 years plus. I've never been more excited about this change. It seemed like a paradox to me that a unified health service at the national level, funded through general taxation, social commitment to everyone, when you get down to the health economy level, was fragmented. Hospitals busy being hospitals, GPs busy in their practices, and so on. It didn't seem like you were realizing the full potential of being an integrated system where you can think about a population of 800,000 people. Now that's changing. These integrated systems could actually do that. The idea is to match the care to the life journeys of the people. People don't come in packages. It's not, you're not a hospital patient and then a ambulance patient or whatever. You live your life. And so can we match care over time and space to the people's lives? And when you have the kind of cooperation you're seeing in the emerging integrated systems, finally you could do that, and it would make sense to patients. It should lower costs actually, and produce much better outcomes.
And you talked at the beginning there about the paradox between having this unified system at a national level and the fragmentation at the bottom. Do you think we can really get to a unified system around patients with the current legislation and architecture we've got? Do we need to throw it all up in the air and start again, or can we just make progress in spite of that?
Well, there are probably some things to change to make it easier. Payment models, for example. Hospitals need to be rewarded for being empty instead of full, for example, because that people want to be home. In my life journey, I want to be home. I don't want to be in a hospital. And payment could have incentives go the wrong way. Regulations can get in the way if that inhibit cooperation at the level you want, the kind of trust Claire's talking about. But I actually think it is all about what Claire's saying. It's all about relationship building and trust. And you can't. That's not written into a contract. That's affect. That's how people care about each other and whether they're given the time and the space to meet each other and plan to really help the population. And it means engaging the population, the kind of shift of power that you're referring to in your third of your three parts. That's crucial too, because I think you'll get more integration when the population can speak up and really express what they want, because that's what they want.
And Claire, can you say a bit more about how you've gone about engaging your population in your work?
Yeah, so I think this is something the local authorities do better than health. So I think health, in terms of CCGs and organisations, always had a responsibility to involve citizens in change. I don't think we've done it very well. Local authority do it much better. So we have taken advantage of the really good relationship we've got, and we've developed a mixed methodology for how to involve our citizens. So if you start with our sort of most hierarchical decision making, we have elected county councillors who sit on our joint commissioning committee. So people that are democratically accountable for the decisions they make are actually involved in work, will be involved in how we allocate the budgets, how agreeing the outcomes. I think that's really important to have that accountability back to place and to citizens. But then we've created a mixed, the mixed methodology how we do it. So we still have the traditional stakeholder 2 monthly meetings where we will have service users, carers, voluntary sectors, faith sectors coming along, and we engage and we talk about plans, and we, as everybody will be doing. But on top of that, we've also appointed citizens ambassadors, so this is jointly with Health Watch, who sit and work in each one of our work streams, so as critical friend. We also have actually lay members sitting in the work stream, so NEDs from each one of the organisations or lay members are also critical friends within the work streams. But the bit that I'm really excited about and that's actually changed my thinking about clinical leadership is we have recruited a people panel. So it started off, Rich, who's leading the work, used to work at Ipsos Mori, and so he started off with going around knocking on doors and actually recruiting people that are demographically representative by postcode. So Surrey is affluent, although we have pockets of deprivation, but the people that tend to get involved in influence in healthcare tend to be the retired, educated population. So we have specifically gone out and over-recruited for carers, recruited for people with disabilities to make sure their voices are statistically significant within the sample size, and have gone around each postcode as well, so our more deprived areas as well as our more affluent areas, to make sure we are getting a uniformity of voice. And then the panel are then sent questions every 6 weeks. So we've done mental health. I think this last couple of weeks we've sent out a cardiovascular question, which is really one of our things we're trying to do is increase the diagnosis of hypertension, because we want to reduce the number of strokes that happen in Surrey Heartlands. So our aim is to have 10 fewer strokes every month in Surrey Heartlands. So to do that, we need to identify people both with atrial fibrillation and hypertension. So some of the questions that have gone out this time have been around who are you happy with, who takes your blood pressure? Does it have to be a GP in a surgery? Can it be in a nurse in a surgery? Can it be in the waiting room? Could it be a pharmacist? Could it be in the supermarket? And gradually just testing with a demographically representative sample what is acceptable.
And Chris, just to bring it on to then engagement of other stakeholders as well, I can see we've got some questions coming through, one from Andrew Jones, who's a managing director of a home care company, and he picks up the point that one of the problems in the STP process wasn't just the lack of engagement of patients and the public that Claire's describing happening so well now in Surrey, but also the lack of engagement of local authorities often, and a lack of thought perhaps to how social care plays a part in some of this work. Can you describe what the ICSs are doing around that? Are they falling into the same traps as STPs did, or is it different this time?
I think it's important to recognise that ICSs provide the leadership across quite big geographical areas, but all of these ICSs have within them local collaborations based on towns and counties, and also getting down to a local level in neighbourhoods and localities. What we've been seeing in our work is the most productive forms of involvement for social care and local authority services more widely are often at that place-based level or within the neighbourhoods, which is important because that's where it makes a real difference to the people we're trying to provide care and support to. The integrated care systems don't do very much apart from providing that leadership and planning, and of course that's very important. The delivery is what happens locally, where people live, the communities they identify with. So I know in Surrey Heartlands there's a strong focus that Claire and colleagues have put on building from the neighbourhoods upwards. They're the foundation stones, the building blocks, then coming together around the towns and the bigger places that really make a difference. And I've seen really good examples of that, say in Greater Manchester, where the local authorities are strong partners in all of the 10 places that make up the Greater Manchester integrated care system, to the point where some of the clinical commissioning groups within the NHS are now led by council chief executives who've got joint roles as the accountable officers for those groups, as well as the chief exec in the local authority. So really encouraging examples of integration and involvement by councils and social care.
And we've often talked at the King's Fund about that being an ambition to integrate health and social care. So where we're actually starting to see it happen, can we see the impacts of that?
we can. So to give another example from the areas we've been working with, if you look at the Frimley integrated care system, a neighbour of Clare's, in the southeast, they've been able to show in the last year or so through the system, but also the prior work done through the vanguards and the new care models that they put in place, they've moderated the ever-rising demand for acute hospital care in A&E attendances, in emergency admissions, in outpatient attendances, in elective referrals by GPs, because they're dealing with patient need much more effectively now by building up the services in the community, including for mental health users in the safe havens that they've been putting in place. And lots of small improvements in care at that local level mean that you see the hospital being more able to deal with the demands of people who really do need to be in the hospital. It's not the most important outcome, really. We should be striving for much more than that around better health for populations and better patient experience. But given the pressures we've seen in the last winter, if you can moderate that demand for hospital care, that's a big step forward.
And Don, I just want to come to you to reflect on that point. So we've talked a bit about what the hospitals, what the local authorities can do as part of the integrated care system. We've had a question come through from someone called Michael Vidal, who's a public representative, and he wants to know what the role of patients should be, what the role of the public should be in terms of contributing to the work of the integrated care systems.
A lot. I mean, a smart integrated care system will invite people to become more involved in their own care. Obviously through better health habits. I mean, that's basics, physical exercise and nutrition and upstream prevention. I think the kind of participation in governance and improvement work and projects that Claire's talking about, that could call on the public to be invited in really exciting ways. I think, I don't know if this exactly addresses Michael's point, but in full flower, the integrated systems will think way out. They're not just going to think outside the box. They're going to think outside the building. They're going to be thinking about all the resources that a community has. Two examples, for example, the table set through the work of vanguards, the new care models, which preceded the integrated care systems. Wigan, which we've heard from this week, it's amazing. They've mobilized resources in the community that cover everything: the schools, the grocery stores, everyone gets a chance to participate in the improvement of well-being. A more focused example that I'm very excited about is in the Isle of Wight, where the person who used to head the emergency care systems developed an entirely new model for handling 111 and 999 calls, in which when you call 111 or 999, you don't just get an ambulance, you get a community, because the hub that receives the call, they know all the resources that could be brought to bear. As a result, most of the ambulances, I think, don't go to the hospital. Most of the people don't leave their home because the needs can be met locally. And so for Michael, that means you may be called on to think differently about how to meet the needs of you and your family and reach farther than the healthcare system for support. And the integrated system will help you do that.
So reaching further than the health system then, if we know, don't we, from evidence that things like people's housing, employment, education, those wider social determinants actually have a much bigger impact on our health than what the healthcare system does. So Claire, have you got any examples from Surrey about how you're thinking about the wider public services and how you bring them into the work of the ICS?
So the wider determinants is one of our priorities and one of our major sort of work streams. We've been working with our local districts and boroughs, who obviously, you know, it's their bread and butter. It's what they do all the time. So as you said, so we know that no matter how good we get healthcare to be, so no matter how good we make our diabetes pathway, we can only affect diabetes outcomes by 20%. And actually, if somebody's housing is terrible, they haven't got a job, they're smoking and their environment is terrible, actually their health outcomes will not improve. So until we bring that, make the relationship much broader than just health, we cannot help, we will not be able to improve the health of our population at all. So we're starting to do work with the district and boroughs, but we're actually looking beyond that to work with the LEPs, with the local enterprise partnerships, actually looking at economic growth for Surrey, at working with partners other than health, which is one of the interesting things I think that will kick off for us next year.
And Chris, we've had a related question actually then around how we bring in the voluntary and community sector organisations. So Daniel Casson, who's from Jewish Care, has asked how the voluntary and community sector organisations can be brought in as full partners. He describes it as being more than just an adjunct to the health system. Any examples you can share with us about how that's being done, if it is at all?
Well, I'd say, to be honest, that's work in progress for most of these integrated care systems. Initially, they were very much about NHS organisations coming together, and then local authorities have got much more closely involved. Surrey Heartlands, Greater Manchester and elsewhere are good examples of that. And the third sector's coming on board increasingly now. But I don't think any of the systems would say, we've got there, we've got to the end of the journey. We know we need to do more in that regard. And just to give the example of Wigan again that Don mentioned, I spent a day in Wigan back in March looking at the fantastic work they're doing in the Wigan Healthier Partnership led by the council. But that is one place where community organisations, the third sector, is at the heart of everything they're doing. The philosophy in Wigan is let's make use of all the assets in our community. And they've invested through their community investment fund, a pot of money the council set aside in supporting community organisations, revitalising community centres and facilities, recognising, I think Simon Stevens described it as the renewable resource or renewable energy that exists everywhere around the country, and the people, the citizens who can contribute far more in many ways than the trained doctors, GPs or social workers. But I wouldn't want to exaggerate or overclaim. I think Wigan is at one end of the spectrum. There are many other places at the other end. It's something we need to do better.
So I was going to come to you, Don, yeah.
I believe Wigan has results already, is that right? This isn't just theory. I've seen data on longer life expectancy, I think by how many years? It's extended by 5 or 7 years, I believe the number was. This works.
And so then reflecting on what you've seen maybe here, but maybe in international health systems as well, Chris's phrase there of renewable energy, can we harness it? Can we capture it? What do we do?
Oh, yes. I mean, the communities want to be healthy and given a chance to participate. We see good examples. The King's Fund, I must say, has been just brilliant at documenting some of the global examples around the world, in New Zealand, in Alaska, in the Netherlands, of systems that have, I want to say exploited, have drawn on the abundance in communities to produce more health. So there are a lot of good examples. The other abundance in the National Health Service, of course, back to the service itself, is the workforce. I mean, people are feeling awfully stressed, but I'll tell you, at least visiting the vanguards, and Claire can comment on her patch, when you invite the workforce to think differently about how to produce health and how to not waste their time and draw on the energies of the public and use what they know, they rise to it, and that would include junior doctors and people, even stressed people in the workforce. Once you open the door to this kind of participation, I think they love it.
And the other group we haven't talked about are the carers. So so particularly, so I know in our patch that we have got a huge carer population that we're doing a lot of work with, because actually if we get it right for the carers, actually designing the system will then be right. And they're a really strong resource out there that have got really good ideas, that really understand the system actually in a first-hand way and can influence really helpfully.
And Claire, we've actually had a couple of questions linked to Don's point on engaging the workforce around how you've done that in Surrey. So Charlotte Tucker, who's from Gloucestershire Care Services NHS Trust, wants to know what you've been doing in Surrey to engage with clinicians. So with clinicians,
So I'll talk about what we've done about that, but I think in terms of workforce more generally, I think we talk a lot about clinical workforce, but there is the non-clinical workforce. And I think that is an area that we haven't done as much with. So we have a workforce action board, as everybody does. And although we have focused on clinical leadership, I think one of the gaps for us is the rest of the workforce. And when I say clinical leadership, I do include social care. So it's it's clinical leadership in its broadest terms as being professional leadership. So we created what we call the Academy, which has very much been a virtual resource for us, where we have centred the work we've done really on clinical engagement. So we've got 5 pillars for the Academy. One is around leadership, which involves how we set outcomes across the system and how we embed those outcomes as a system, and then with each one of our places and each one of our organisations. We've got the engagement work, and we're about to set forward a similar methodology as we've done for citizens with our workforce. So again, so we can have demographically representative. So make sure we include the AHPs, make sure we include nurses both in primary and in secondary care, make sure we include GPs, make sure we include secondary care. So it's not, our model has been medically dominated at the moment, and we need to get those broader voices heard. Third pillar is talking really about how we join up the data, so we create one data set for Surrey Heartlands and make sure that it's clinically relevant. We've done a lot of work on QI. So the clinical director for our academy is a chap called Mark Hamilton, who is Associate Medical Director at St George's, as well as working with us. And he's on the Foundation Q Fellowship and has done a lot of work with IHI at George's. And actually we've had IHI in the system last week, working with all our organisations, because we've got some that have an IHI background, some that have got a lean background. We've got community sectors that have done no quality improvement. And actually what we're trying to do is create a common methodology and a common language, so that, because one of the things that often divides clinicians is saying the same thing but using different words, and then you end up having a half an hour Barney, but you're actually all saying the same thing. So trying to create a common language and common methodology, but also the QI stuff that's going on is going on at grassroots, and it's real. So how do you harness the really good work that's going on and then spread that around the rest of the patch? And then the last pillar for the academy really is around innovation. So we're in partnership with the Academic Health Science Network, and we put on an expo in Surrey in March and February, and Chris came down, and that was preceded by a call out to grassroots asking, so what is the innovation, what is the digital example, how do you think we could do things better? And then we then brought industry partners in that matched that call to then meet, and had about 200 of our workforce that came in to do that. So we would plan to repeat that. We've got the other thing that Mark's doing through the academy is setting up a thing called Clinical Connect, where we want to create a forum for as many people as possible to come in and meet physically 6 monthly, but then also to connect virtually. So through creating a workforce panel and a clinical panel that can give information, but can also be a two-way conduit.
So lots of examples already, I think, of local progress, which you've all been able to describe, really encouraging things we're hearing. But we're getting a few questions through around what's happening elsewhere. So a question for you, Chris, around how we can encourage this through policy, I suppose. So Joe Parry from Public Health England has said, how can we persuade stakeholders elsewhere to engage with integration when it's not incentivised by the Department of Health? And so what should the Department of Health be doing to encourage us elsewhere to be doing the sorts of work that we're seeing in the places that have been described so far?
I think partly it's building on what Jeremy Hunt has said as Health and Social Care Secretary on many occasions. This is the future. Integrated care, population health, whatever language you care to choose, must be at the heart of the new 10-year plan. View we've also heard from Simon Stevens, and I think NHS England, NHS Improvement probably can do more to remove some of the barriers and the obstacles than the Department of Health can these days, given the changing roles and responsibilities at a national level. But I have to say, I don't find there's a lot of resistance to what we're talking about here, the work of the integrated care systems. If you talk to doctors, nurses, AHPs, frontline staff, it makes absolute sense. If you talk to patient and public representatives, they're saying, well, why aren't you coordinated and integrated already? I think we're pushing at an open door. If there are obstacles, it's back to where we started. It's around the legal context. And in fact, at the moment, the way the NHS is run, it's the organisations running hospitals, community services, mental health services that have the statutory responsibilities, and they're being held to account by the regulators at a national level. And sometimes, I have to say, the way those regulators works against integration, because they're still working down the silos rather than thinking about how they can regulate and support these systems of care. So if we really want to make this work everywhere, the regulators have to change their behaviours and ways of working. They have to be consistent in following through on what the national leaders have been saying. And we've got to find ways of helping people in areas where the basic trust that Claire and Don have referred to doesn't exist. because you need to build that trust. You need to leave behind the competitive behaviours that have existed over the last 25 years and start to work much more in partnership. Easy to say, hard to do. You've got to make the investment that Claire's referred to, that she's committed to in Surrey Heartlands, of time and effort to enable those organisational leaders to change their spots, if I can put it that way, to be great collaborators and partners rather than necessarily the competitors they've been in recent years. And all of that takes time. So we've got to allow these nascent systems the opportunity to mature and to grow and to overcome some of those historical barriers.
Time and effort, though, how can we find that at the moment when we know that funding's tight, we know there are workforce pressures? Is this an uphill battle? What can we do around that?
So there is an uphill battle. I'm sure Don will want to comment on this from what we've been seeing this week and on his previous visits. You can't mandate that. It's got to come locally from the leaders and from the staff who are trying to work differently in this much more integrated way. If they don't want to participate, you can't force them to. At any time, I said right at the beginning, integrated care systems are voluntary collaborations among many different organisations. Any of those organisations at any point can decide they want to walk away, and that's entirely their right to do so. I'd be disappointed if that were the case, and I'm not aware of many examples where it's occurred. So that local commitment, the local leadership, and then finding the time and a bit of money and resource. And one of the benefits, of course, of being an integrated care system is they are receiving a bit more funding, sometimes capital investment, sometimes revenue support, to create the headroom and the space, but it has to happen locally.
Creating headroom and space in Surrey, how have you done that?
Yeah, so what I think is really interesting is the transition from STP to ICS. So STPs arrived, a couple of years ago as being a top-down, and it was very much a, you will all come together, you will all write a plan, and you will all have a number in the bottom right-hand corner that matches, and go away and come back until you've done that. So that's not terribly conducive to partnership working. And where we got to quite quickly, which I think was the advantage, was that realisation that we needed to work together. So because we had a number of organisations with financial troubles, a lot of sustainability issues around workforce problems, and actually if we didn't do this together, that as a place and as a system, we would end up failing. So that then alters the conversation. So instead of it being something we have been told to do and it being about money, actually then it becomes being something that we need to do to actually make sure that we improve care of our citizens and also make Surrey a better place to live and to work. And and you need to alter the narrative to being something that you want to do and having a clear reason for why you want to do it. So as a leadership group, we then started talking about our tenure of stewardship of the health and care system of Surrey Heartlands, and actually an intent to improve it. So as we all moved on, that actually health and care would have been improved, which is a million miles away than make this number match in the bottom right-hand corner.
And so, Don, reflections on that. You've seen the STP process from afar, you've seen this process from afar. Any thoughts?
Yeah, I mean, I don't want to minimize the potential toxicities of some of the policy environment. I know policy is never perfect, so some of the regulation, some of the payment, it's a bit uphill, more than a bit for some, but it's back to what we were saying at the beginning. This is about trust, and I would say to the people that aren't ICSs but would like to do this is act your way into cooperation. I mean, cooperation doesn't require a law, and it's not stopped by a law. It is a little harder if the payment system doesn't encourage it, but this may be a time to take some control. David Nicholson, who used to be the head of the NHS, was quoted yesterday as saying at one point, "Don't ask." And I think that's right. Don't ask. Do it. If you want to work together better, start working together better. I think the payment systems will catch up. The regulators are quite alert to this now. I'm hearing a lot of stuff at the, in the center about can't we do better at this? The Wigan story, that's not a story of someone requiring Wigan to do something. Those are a group of people and a leader that said, hey, let's just get about this. I remember visiting, was it Winslow? I was trying to remember where they were doing amazing work, a little smaller community, but And I asked the GPs actually had started it in cooperation with the citizens, and were doing amazing work on integrated care, keeping people at home, getting them out of the hospital sooner. And I said, how do you do this? And the GP leader said, it's the pub. I said, what do you mean? He said, well, we meet in the pub. And I think that kind of confidence and sense of locus of control being internal, I like it. So we'll work at the policy level, of course, but get about it.
Can I just add, Anna, to that, as the saying goes, where there's a will, there's a way. And the areas that are making progress have found a will to do so. But not everywhere, and I would recognise, I think, the point behind the question. Sometimes it feels like it's wading through treacle to get all these organisations, and they're running to 20, 30, 40, sometimes in the bigger of these systems, to find common cause around their population and how they can best use their resources. And if that's the case, what I would say is let's focus down back into those neighbourhoods, into the local places where there's often a very strong identity and much more willingness to come together around a place that people feel a real affinity for. So leave the treacle behind, start making small changes, getting the GPs working in a much more joined up way with the community nurses, with the social care staff, bringing mental health into that for a population maybe of 30,000, possibly 50,000. This is happening everywhere. That doesn't require organisational leaders to agree on everything, but if you can get your staff at the front line doing that, good things will happen.
So if I'm a GP or a district nurse or a physiotherapist working somewhere in the country and I don't feel this is happening, what can I do?
You could just get on with it, in my experience. What we've seen, Don and I, on our travels around the new care models, is this is where the most important changes have taken place, where you've given the headroom and the space to GPs, nurses, mental health staff, social care staff, the third sector. A wise man once said to me a long time ago now, 20 years ago, for every problem and challenge within the NHS, there is a solution. And the solution is held among the staff delivering the care. And the role of the organisational leaders is to create the time and the opportunity for staff to get off the treadmill of doing the day job and find a way of improving that and introducing new and better ways of working. So I'd say to the GP and the community nurse, go and knock on the door of the people who control the purse strings. Allow you to do those things that you need to do and you know need to be done, and then patients will see the benefits.
Any thoughts on that from Surrey, Claire?
So I go back to, our probably most advanced integrated place is probably around Epsom. So Epsom Healthcare, a couple of years ago, applied to become one of the vanguards. I'm not being bitter, but we were not successful. And obviously I've got over it. But nonetheless, so we didn't wait for permission. We just carried on and we got on with it. So created a way of working that brought together the Acute Trust, the GP Federation, the local authority, working with patients, working together to create Epsom Health and Care. And they've now been going over a year and are starting to see sort of similar stories with Frimley. So 5% reduction in non-elective admissions for the over 65s. 1 day knocked off the length of stay for that group, and fewer A&E attendances compared to the peer demographics in other areas. And so that was without any extra funding, that was without any extra help, that was really just a commitment to, we know this is the right way to look after patients and this is what we should do. And the thing that unlocked it, I think, or the thing that made a real difference was the, in seeing, so all of our GPs now in Epsom are all on EMIS. And it was the sharing of the ability to see the EMIS GP record in neighbouring surgeries, but also in the hospital. So the Epsom Health and Care teams can look at the GP record, and when you have a phone call about a patient, you can do it seeing the records, and they've got a control room so all members of team can see where people are. So it's the sharing of the record, but also the sharing of the responsibility for the people that we're looking after.
And I just want to pick up on a question for Don, actually, that picks up on some of your points around this really being about, well, all of your points about this being about relationships, about being collaboration. We've had a question from Bob Claber from Imperial, who I believe you know, a paediatrician, and he's asked if it's all about relationships and the sorts of things you've described, but as an expert in improvement yourself, we hear a lot about the importance of measurement for improvement in healthcare. Have you got any thoughts, you or the rest of the panel, on how can we measure these things that we know are sitting behind some of this development, so relationships, connections, trust?
Sure. You have to change the psychology of measurement. In England, as in many countries, you're not alone, in many organizations, measurement has become too much the master, and it's impressed upon the workforce as an external agent of change, or some idea that if you measure me right, I'll do the right thing. It's not really true at all. It all begins with purpose. And so when we're in the kind of environment we're talking about now, where people like Bob Claber can take the ball and really create something new, as Bob has done, as we've seen all over this country, a Duncan Gooch at Arawash, or Andy Knox and Markham Bay, I could just recite these people, these emerging young, often leaders. They'll turn to measurement then to figure out how it's going. And measurement becomes their servant. And I think that's the psychology that will work in the integrated care system, where it's a local tool, that's all. And then, of course, we can help devise measures. And in this country, has been pretty smart about measures. At the superordinate level, understanding what's happening to your survival rates and your complication rates and your patient safety, I think the center can help with that. They can supply it. But measurement is a support, not a battering ram, if it's used properly. The other thing I'll say about measurement is a little bit higher level, but we were talking about trust, crucial, but I think the trust is driven by purpose. Trust is a relationship in pursuit of something. What kind of country do you want to be? What kind of population do you want to have? Healthy, vibrant. Well, how would you know? What can we know about that? But measurement is a reflection of purpose. One in particular, I'll say, and I'll stop in a second. It has to do with equity. All countries suffer from pockets of poverty and deprivation and unfairness. There's the lonely elder, the person of color who hasn't gotten access to the mainstream of society, the person who has no income and really is suffering. And I think one of the purposes you have in the NHS, and I hope you'll preserve it and can unite you, is your intent to help the most disadvantaged. And that's a way to build some trust. If we agree as a community, we're going to do that.
Yeah, so I think it's really interesting. It's one of the things that I've found quite difficult in terms of, it's very easy to count things and measure things, but actually, are they meaningful? And that's, again, has been, I know I keep coming back to local authorities, but that's because actually that's been my richest area of learning in how we should represent things. So when we talk to our county councillors, they will say, well, that's all well and good, but what does that mean for my residents? And so instead of going from saying we're going to increase the number of people we have found with atrial fibrillation, or we're going to improve the anticoagulation, you need to say we will have 10 fewer strokes in Surrey Heartlands every month. That is something that is meaningful to the population. And then and we're also obviously moving to measuring things that matter around the wider determinants and social determinants. And when you start to look at that, that's really, because a lot of that is really long term. And so one of the things is obviously to improve the life expectancy, but it is more complicated than that, and it's to your point, because actually if you just target blanket to improve the life expectancy, we've already got really good life expectancy in Surrey, but we've got a gap. And actually, yes, we should be improving the overall life expectancy, but we should also be narrowing that gap. Is actually the measure that is as important, if not more important, than improving the overall life expectancy. So I think it's really interesting, and I haven't got all the answers on it at all. And when I first heard the question, I was thinking, is he talking about how do you measure trust? And that's where I sort of first went with that. So how do you prove that trust has improved other than by the overall outcomes? And I don't know.
Any thoughts from you, Chris? Measuring trust?
I'm grateful for the question, because I hadn't thought about it before. And I've got kind of two conflicting responses, which is it's probably impossible to measure relationships, because They're so important but so intangible. But then a further thought would be, well, if we're going to try and do that, maybe we need something like an organisational 360-degree assessment process. So the partners involved all contribute to making some judgment about how they feel the relationships are, because unless you're at the heart of these partnerships, it's very difficult to say that. I'm also thinking about the experience that local government has. So the peer review processes that local authorities have used and the sector-led reviews, I think that's the right language, is a way of getting some external help on that. So you might invite in, a neighbouring local authority to come and have a look at whatever it is and give you their judgment on that. So I suspect it's about triangulating the softer, the harder, the peer review, internal, external processes to make some assessment. But I just go back to the point, it's quite hard to measure in a traditional way.
Yeah. And peer review, Don, I think yesterday we were visiting West Yorkshire and the integrated care system there, and I think peer review came up as an option of something they were exploring. From your experience, is that a powerful tool for measuring what we're doing for improvement?
Well, it has many different meanings, the term. I would say in a trusting environment, when we're trying to be more cooperative together, we help each other get better. So if I'm on a good football team, I imagine we play the game, and then I go to the other place. How did I do? Did I pass correctly? Yeah. You want to know, and I guess that's peer review. I want the people I work with to tell me how I'm doing for them. Far different from an audit mentality. It's a curiosity mentality, and in that sense, I think it's wonderful when that happens. And as I was saying yesterday in Yorkshire, if the leaders would sit around a table and each one asked the other, "What could I do differently that would help you? That would help you help Mrs. Jones?" I think that's a form of review that I totally endorse. In the external surveillance world, when the auditors are showing up and you're about to get your score, that actually decreases because you're trying to get through the day. And get through the measurement. You're not trying to learn. You're trying to be safe, and that's not good. But in the healthy, integrated world such as Claire is leading, people want to know how they're doing, and they'll ask each other.
Does that answer your question, Claire? Or?
Yeah, no, so the 360 thing is really interesting. In that, so again, I'm going to talk about David Berg again, the guy from Yale. So he talks about, 360 feedback, you have to be really careful. If you do 360 feedback in a hierarchical organisation, you will never get real feedback, because there is already an imbalance. If you are at the top, in hierarchicals, if you ask your team in an anonymous way, you won't ever really get true feedback. And the only way you can do it is to take people who work for you and have them talking to somebody anonymously to then have them feed it back. So you have to put, and again, I'm thinking as I'm talking, but in terms of if you're going to do a 360 of a system, so yes, you've got an absolute equal level playing field, so that would work. But I think it's really difficult.
Well, even in the system, I suspect there's hierarchy.
Yeah, well, yes.
Yeah, between the organisations and their leaders too.
Yeah, so I think, so I haven't got an answer, but I think it's interesting.
So we've had an interesting question through from Louisa Petchy from Age UK. And she's asking, and Chris, maybe this is one for you as someone that's been around all of these systems, do we need to be worried about variation? So if there's some really good stuff happening in some places, but we know there's a spectrum here and some places are motoring on, some places aren't, do we need to worry that variation across the country is increasing?
No, I think what we should welcome is experimentation and innovation and testing out new ways of working, and I've seen some fantastic examples of that in the 10 integrated care systems. What we should worry about is how we then spread those innovations and share and adapt them in different environments. That's an age-old problem. Over 70 years, the NHS has never done that very well. And I hope that the communities of practice that we've been working with, bringing together the 10 systems, are a small start in that sharing and spreading.
Don, sharing and spreading, any insights on how we do that? We know it's tricky.
I agree with Chris, in some ways you want more variation because the wisdom of the field trying things out will teach us about things we wouldn't otherwise have thought of. So Claire's going to come up with something in Surrey Heartlands that nobody ever thought of. And the spread issue, which is how do you take that emerging knowledge and make it available to everyone, is unsolved in the NHS. I think everybody kind of knows that, and I really would love to see this system experiment a lot with new ways to move stuff around. There's one small piece of Louise's question I will comment on, which is, if we really want to cooperate and smooth things, there'll be forms of standardization that will feel a bit uncomfortable. Because I would say variation is good when it teaches us, but there's also stupid variation, which is just we have not agreed to do it the same way. It'd be like if you built a railway system and every system has different track widths. That doesn't make a lot of sense, and there's no right track width, but agreeing to do it the same way is a form of smoothing experience. And that's a step of maturation. When you're in a control-oriented environment, it feels like an assault on you. But when you're in a cooperative environment, you can sit around a table and say, hey, why don't we all agree to do this the same way and then make it happen? And I think there's a lot of mileage there too, for just to save money and make things easier for everybody.
So we've got variation even within Surrey Heartlands. So we have 3 places, which we call our integrated care partnerships. And it's really interesting you say, because actually as our ICPs develop over this year, we're having the conversations about, is it okay for them to all develop in different ways? And we've now come to the conclusion, no, there are some things that need to be the same in each one of those places. And so it's the setting the outcomes as a system. So as a resident, the outcomes you can expect wherever you live are the same. But there's actually probably something around the governance looking the same. So the way we make decisions, what the decision-making structure will look like in the ICPs. And we're talking about the way we do contract and the way we do financing. But actually, how you, as an ICP or as a neighbourhood, decide to deliver those outcomes, that will look different, and that's okay as long as the outcomes actually are the same for the people that live there. But it's interesting because that's exactly the phase we're going through at the moment, is actually realising there are some things that need to look the same even within the one system that we are.
And we've had a question through for you, Claire, from Dominique Black, who's from the Care Quality Commission. Yeah. And she wants to know about your devolution deal particularly. So she said we've heard quite a lot about the devolution deal that you've got and also Greater Manchester. So what is the difference that it makes for you compared to the ICS areas that don't have that? And particularly, does it make a difference for people in the population, people using services?
So our devolution deal is about the uniting of the public sector spend so we can make decisions at place about our population. So it all gets a little bit, no decision about us without us. It is sort of, it is the, if you pare it right back down again. So it's the being able to unite the health spend with local authority spend, look at how housing plays into that, look at how education plays into that. So it's very much, it's the broader, the wider determinants piece, actually how you use all of that to actually influence health outcomes. So we've got some very technical transfer of NHS England functions. So Matthew Tate, who's our joint AO for the 3 CCGs, is also employed by NHS England. So he has 2 contracts, and because of that, he can then take, well, he will then take some of the NHS England direct commissioning powers. And that's quite technical and has taken quite a long time. But the essence of the devolution is really about the uniting of the spend to make decisions locally that matter to people at place.
And I just want to pick up as well a question around the involvement of mental health. Maybe we'll talk about it in Surrey first and then come out to the big picture. So Chris Naylor, who's one of our senior fellows here at the King's Fund and is watching with a workshop group, watching the session today, they want to know how we can use integrated care systems to redress the balance between mental and physical health, and can we make the most of opportunities to improve mental health and well-being across the system? Yeah.
So mental health is obviously integral in everything that we do. So a couple of things to talk about that really. So each one of our work streams, whenever we review the work streams, it is always the how have you involved mental health, how have you involved prevention, and how have you considered the impact on primary care? So they're the 3 sort of standard questions that we ask all the work streams to always consider. We're doing a piece of work looking at what happens at each level. So what happens at neighbourhood level, what happens at ICP level, and then what happens at system level and what happens at beyond system level. And actually the mental health bit is really interesting because mental health is so integral to everything that we do that each one of the places is saying we must have mental health in, because actually we as a place will need to invest more in mental health. So our Guildford system has obviously they've got a university there, and they want as a place to be investing more in the mental health of our young people, because they have a greater unmet need than elsewhere. So there will be more investment because of the integrated working, rather than if we were doing this in a more traditional way.
It's really interesting. And Chris, I wonder if there's anything you'd add to that from what you've seen across the piece in terms of opportunities to maximise mental health and well-being?
The best examples I've seen have come out of the new care models that are now being picked up within the ICSs, and the one example I'll give is in Frimley, where mental health has been a priority in the Vanguard programme, and they've offered new ways of meeting mental health needs in part of Frimley through the development of the safe havens in that area, which enable people with mental health needs to go not to a traditional specialist mental health facility which the NHS runs, but to go to shops in the high street which offer a safe haven with people who are there experts by experience. They've got expert mental health staff as well. And what they're finding is that that's a very accessible form of delivering a different mental health response to people's needs. It's contributing to what I was saying earlier. We know a lot of the demand on our acute hospitals is from people who've got mental health needs and physical health needs. And when you look at the overall reduction they're seeing in that demand, these small, important changes, including mental health services, have definitely contributed to that.
And a more sort of a fundamental question then we've had through from Rebecca Cooper, who's a consultant in public health. Perhaps I'll put this one to you first, Don. She says, have we got enough time to see the maturation of integrated systems before the next wave of change engulfs the NHS?
Well, change will come, Rebecca. Yes, you do. I mean, it is investing for the long haul. These changes take years, not months, but this is the right thing to do. This is sharpening the tools so you're ready when the next thing comes. I think behind Rebecca's question is a very interesting additional point, which is, okay, you know there's going to be a headline in The Guardian, or some crisis will emerge, or there'll be a big flu epidemic in this winter. I don't know. Are you going to be constant in your purpose? Constancy of purpose is one of the first rules of improvement. So you have to be mature enough to say, we're going to deal with this incoming crisis, whatever it is, the one we can't anticipate, but let's not forget we're on a journey and that's the destination. And I think you've got enough, I know you've got enough maturity in the NHS and in leadership and in the country to do that. Don't lose sight of the star in today's storm, but you have to deal with both. I think you can do that. You know, if this is done right, the movements toward integration that we're seeing in the successful places, they will free energy to deal with the crises. That's where the pot of money it may be to be more resilient when the flu epidemic hits, or the unexpected hits. You've got to deal with Brexit. You know, it's going to change the whole workforce pattern here. But you can do that and also get these new systems up and running.
Do you agree with that, Chris? Can we withstand the prospect of further change?
Well, there will always be further change, won't there? I suspect the best way of trying to future-proof what we're talking about, the integrated care systems, is to make sure that the 10-year plan that we're expecting later in the year has integration and the work of these systems at its very heart. And I'd be astonished if that isn't the case, given the commitment we've already had from Jeremy Hunt and from Simon Stevens. There is no plan B. It's how we make this work.
And Claire, what about you? How are you going to keep constancy of purpose in Surrey Heartlands? Are you going to?
Of course. So I think the thing that would be really interesting is, so the regulators currently are talking about moving to having a single system conversation. But when we hit winter, if one of our A&Es isn't performing as well as we would like, are they going to phone up the acute trust chief exec, or are they going to phone up the system? And I think that will be the real test as to whether the regulators are backing the changes or not.
So lots of progress made, more still to come. We'll watch this space. Perhaps we'll come back in a year and look back on 2 years of integrated care systems. We're sadly out of time, but I think that was a perfect question for us to end on. So thank you all for your contributions. Thank you all for your questions, which we've had so many of. I have not been able to ask all of them. So if you are interested in hearing a bit more, learning a bit more about the things we've been talking about today, please do take a look at the links and resources that you'll be able to find on the webpage that this event has been on, and also look out for a new report that we'll be launching in September, tracking progress in the first integrated care systems. That's all we've got time for, so thanks again for joining us. Thanks all for joining us, and we look forward to seeing you again for the next online event.